Well, good afternoon. My name is Cristian Milla. I'm a research fellow at the Cleveland Clinic, Florida. I want to thank the chairman, my mentors, and SAGES for the opportunity to present this study. So I have nothing to disclose. So heart disease is responsible for over 600,000 deaths in the United States every year, and it is the principal cause of death among all ethnic groups. Some well-known risk factors for heart disease include high blood pressure, tobacco, smoking, high cholesterol, and obesity, also diabetes. So when we reviewed data from the CDC of the most common cardiovascular diseases by ethnic group, we found a higher prevalence of the most common among African American population, like coronary artery disease, acute myocardial infarction, and hypertension death rates. And when analyzing the total cardiovascular disease rate among ethnic groups, same findings, higher prevalence among African American. So as you know, in the last decades, the prevalence of obesity has been steadily increasing in both adult population and youth. And when analyzing the prevalence of obesity among ethnic groups, we found that higher prevalence of obesity among Hispanics and African American. So the objectives of our study is to analyze if ethnicity plays a significant role in bariatric population outcomes, specifically heart age and atherosclerotic cardiovascular risk score. So this is a retrospective cohort study where we analyzed patients that underwent bariatric surgery at our institution between the years 2010 to 2015, and we proceed to analyze demographics, comorbidities, heart age, and cardiovascular risk score. We created 3 categories for analysis purposes: Caucasians, African Americans, and multicultural. This last category was composed of about 90% of Asian population. We calculated the heart age using the Framingham Study Heart Age Calculator and the cardiovascular risk score using the ASCVD risk score calculator from the 2013 American College of Cardiology and American Heart Association guideline, which is the latest one. So this is an example from the Framingham Heart Age Calculator of how a patient can have a real age and a very different cardiovascular age if he's subject to these factors like smoking, high blood pressure, diabetes, or obesity. And this is a sample of the actual calculator taken from the Framingham website. So after inputting all these variables, you are able to have a numeric value of heart age. We use the Framingham Heart Age Calculator because it has been a pioneer for risk concept. So before the Framingham study, conditions like myocardial infarction or diabetes were considered to be just a natural process of aging. Also, it has been the gold standard for risk assessment for 50 years. And one weakness is that it has not been as widely validated for Asians, Hispanics, and Native Americans. That's why we also included the ACVD risk score, which after inputting all this data, you get a 10-year risk of developing coronary artery disease, cardiovascular disease. And less than 5% is low risk, from 5 to 19 is intermediate risk, and more than 20% is high risk. And the benefit of this one is that it has been validated for all ethnicities, and it's a very good tool to start discussion with patients and to start medications to prevent mortality, like statins. So these are the results of our patient demographics. There are not many differences between our categories, except the big difference in number of patients that responds to our patient demographics in South Florida. So we analyzed about 300 patients with a mean age of 52 years old. Most patients were female, 67%, and the most common procedure performed was laparoscopic sleeve gastrectomy, with over 73%. The preparative BMI was 41, the mean, and at 12 months follow-up was 30. So this is a very interesting chart. So on the pale blue column, we're going to see the age at the time of the heart age at the time of the surgery. On the yellow column, the heart age at 12 months follow-up. And the green line, the actual age of the patients. So first point is that all categories had a clear benefit from the surgery in terms of heart age. The second point is that in the African American group, the benefit is not as significant as in the other 2 categories. And the third point is that in the multicultural category, the initial heart age is not as high as in the other categories. And we had the same findings when assessing the ACE risk score. So in the dark blue line, we see the initial risk at the time of surgery. Pale blue at 12 months follow-up. So All three categories had a clear benefit in the risk reduction after the surgery. African American population had not as big decrease in risk, and in the multicultural category, the initial risk is very low compared to the rest. So the limitations of our studies, that is a retrospective study, we had a lot of loss follow-up, about 30 to 40% at 1 year, and it's a very small population that we were able to get all this information. I would highlight as a strength of this study that it's the first study that we found in literature assessing this particular topic. So in conclusion, ethnicity does not seem to impact weight loss after bariatric surgery, although we found a clinical significant difference in reduction of heart age and cardiovascular risk reduction among different ethnic categories. Thank you.